Hello, my name is Byron Pertades. Today I'm going to be lecturing on the pathophysiology and the pharmacological interventions of heart failure. Heart failure is simply the inability of the heart to pump oxygenated and deoxygenated blood throughout the body. The inability for the blood to circulate causes a leakage of fluid from our capillary vessels, which flood or build up fluid in our body, or another term, congestion. That is why heart failure is also known as congestive heart failure, or CHF. Okay, CHF is a common and fatal cardiovascular disease that affects many adults from various ages, especially, but more specifically, those of the older population and those affected by weakening of the heart. Common causes for CHF include coronary artery disease. Coronary artery disease is the blockage of plaque in the arteries supplying blood to the heart. So if the heart is not receiving blood or oxygen, then the heart muscle dies and gets weak. Other causes of CHF include hypertension. In hypertension, increased pressure makes the heart have to pump harder or work harder to pump blood throughout the body. This causes the muscle to become weak. For example, bodybuilders, they work out and their arms become stiff. Just like a muscle in the heart, they need to grow muscle, and eventually they grow stiff and weak and unflexible or unelastic, which leads to heart failure. Other causes of CHF include obesity, diabetes, history of heart attacks, drug abuse, alcohol abuse, just to name a few. So what is CHF? CHF can be classified in two classes. We have systolic dysfunction and diastolic dysfunction. Okay, I have an example. This is what I've used to learn to the two differences. Systolic dysfunction, we're taking this water bottle as a heart, the fluid as the blood, and this part up top is the rest of the body. Okay, so systolic dysfunction is the inability of the heart to contract enough pressure to raise the blood throughout the body. So if this squeeze is weak, then blood does not flow efficiently. This is called ejection fraction. So ejection fraction is the amount of blood that is ejected out of the heart, given the size of the heart and how much blood is inside the heart. Okay, normally normal ejection fraction is about 60 to 50% normally. People with ejection fractions of 30% are considered to have systolic dysfunction. All right. On the other hand, we have diastolic dysfunction, where the heart has the inability to relax. What that does is the heart is unable to fill. So if it's contracted and blood does not fill, we are left with minimum amounts of blood in the heart. So when the heart contracts and tries to get the fluid out, it's actually very hard to get the blood circulating through our body, and that is known as diastolic dysfunction. One of the key points is that diastolic dysfunction, the ejection fraction for those people is actually normal. But when you further look and investigate, the heart muscle is actually weak, and it's the filling property but not the contraction property. All right, so what else can we consider heart failure? Heart failure can be also broken down into left-sided heart failure and right-sided heart failure. So we have a heart, and let's see, I'm not the best drawer, but I'm gonna try my best. That's not too bad. Okay, so we have right side heart failure, left side heart failure. This is the right side of the heart, left side of the heart. So the blood from the left side, what it does is it pumps blood normally out of the body. So out of the body. Body. Oh, body. Body. Okay? From the left side, pumps blood out of the body into the right side of the heart. Okay? From the right side of the heart, blood goes out into the lungs. Lungs. And then back into the left side. And so forth. Okay? So the left side has oxygenated blood to the body, back to the heart. Then the right side has deoxygenated blood, goes to the lungs, and exchanges the carbon dioxide for the oxygen. Okay? So in left-sided heart failure, what happens is the left side has the inability to pump blood to the body. So the forward action or the preload, what happens is there's not enough blood that gets to the heart, not enough oxygenated blood that gets to the heart. So what happens is people become diaphoretic, sweaty, fatigued. The heart has to compensate, so it beats faster, it pumps faster just to get the blood back around to the heart. So you'll feel palpitations usually. The other heart failure for the left side is the afterload, so the backflow. So when the left side is not able to pump blood, it backs up into the lungs. So that's where you see people with pulmonary congestion. You have wheezing, coughing, you have wet sounding lungs. On the opposite spectrum, the right-sided heart failure, right-sided heart failure has deoxygenated blood, which needs to be pumped to the lungs. What happens is not enough blood gets to the lungs for oxygen exchange. So you'll get patients or people that have shortness of breath. They need oxygen because they need to exchange the deoxygenated blood with oxygen. Okay? The other side, or the preload, happens when the right side of the heart is unable to get to the lungs and it backs up. From the right side, it backs up to the body. So this is where we will get people with edema and swelling, usually in the hands or the feet because of gravity. Okay? And usually you'll get patients or people with jugular distension. Okay? So what happens? What do we do about this problem? Unfortunately, CHF or congestive heart failure is irreversible. We can't fix a broken heart. We can only manage symptoms, and through pharmacological interventions or through lifestyle changes or cultural changes, such as diet, eating foods that are low in salt. Increasing salt intake, it also increases blood volume and water retention. So we want to avoid salty foods. But the biggest thing is learning how to manage pharmacological interventions in people with CHF. So how I learned how to remember these drugs is simple. It's ABC, right? ABCs. That's a simple thing to learn. We'll add a D because D is the most important. So drugs. We have drugs here. Okay. You have A, B, C, and D. Okay. A stands for ACE inhibitors. Okay. ACE, A, C, E, I. Inhibitors. The way I like to remember ACE inhibitors is the last four letters. It ends in pril or P R I L. Pril. The most common ACE inhibitor for CHF is lisinopril. Pril. Okay, So what do ACE inhibitors do? ACE inhibitors are angiotensin converting enzyme inhibitors. So when we take ACE inhibitors, or we ingest ACE inhibitors, the enzyme converting angiotensin combines with angiotensin 1 in our body and converts it to angiotensin 2, which then in turns inhibits or stops the secretion of aldactone. So what's so important about stopping aldosterone? Aldosterone, I'm pronouncing my words. The aldosterone is responsible for the uptake of fluid in our kidneys, which then increases the sodium intake in our blood volume. So ACE inhibitors, what it does, it inhibits that secretion, so it prevents uptake of sodium and decreases volume. So the two key points that ACE inhibitors do is they decrease lower peripheral resistance, so decrease resistance, and they decrease blood volume. So peripheral resistance, lisinopril is actually known to be a hypertensive medication. So it helps reduce hypertension and it reduces the blood volume for the heart to pump efficiently. Okay? So what are the side effects of lisinopril? One of the biggest side effects of lisinopril is hypotension, okay? Because it's for hypertension medication. Most of the times, people want to check their blood pressure before taking this medication. Having already hypotension or low blood pressure will cause people to get dizzy, to experience orthostatic hypertension. A lot of people get up too fast and then they end up falling down. So monitoring your blood pressure is important. Also with ACE inhibitors, it's also important to monitor your potassium intake. For ACE inhibitors, there will be an increase in potassium, so you want to be mindful about what you eat and other medications that you take with lisinopril. Okay. B. What does B stand for? Beta blockers. So beta blockers. Beta blockers. I remember this by LOL. LOL. The common drug for beta blockers that we use for CHF is carvedilol, and metoprolol EX, or extended release. What do beta blockers do? Beta blockers block beta receptors in the sympathetic nervous system that potentiate the cardiac muscle. What this means is it decreases, or it does two things. It decreases the work load of the heart and also decreases oxygen demand. So the heart requires less oxygen, and also it takes the workload, or the pump, it gives the heart basically a break. Okay. Being that said, beta blockers will slow down your heart rate. So one of the considerations is hypotension. Bradycardia. So it is important to take your pulse before taking this medication or taking metoprolol. It also does hypertension. So taking your blood pressure and also your pulse is very important with this medication. C is cardiac glipicides. So cardiac glycosides. A common one that we use is digoxin. Digoxin. Okay. Digoxin. Cardiac glycosides, what it does is a positive inotrope. So it increases the contractility and the myocardiac contraction of the heart. So it's making the heart push harder so that the blood can flow. Example I like using is like a ketchup bottle. That the pressure it puts on the heart to push out all the blood is what cardiac glycosides like digoxin do. Okay, since it fires and it contracts the heart, one of the things that digoxin also does is it lowers the heart rate. Okay, so one of the side effects of digoxin is bradycardia again. So it's important to go ahead and check your pulse before taking the medication. Digoxin is considered the second line of drug because of its side effects and its toxicity level. So it's important to make sure you don't take digoxin too long or have your blood levels checked for digoxin serum levels to make sure it's therapeutic. Digoxin is also known to cause cardiac heart dysrhythmias, so irregular beats, because digoxin also increases your potassium levels. So be mindful about what you eat. Make sure that you're not taking potassium supplements when you take digoxin, because then it'll affect your heart. D, what does D stand for? D is diuretics. Let's see, D. Diuretics. The common diuretic we use for mild to severe CHF is Lasix, or loop diuretic. Lasix. Okay, so what do diuretics do? Diuretics try to get rid of the excess water, okay, the excess fluid through urine. It lowers blood volume. Okay. It also increases cardiac output. Okay. Also, it treats our symptoms of CHF, like pulmonary congestion, and our swelling and edema, because it eliminates the fluid from our body, edema. Okay. The considerations for taking Lasix, we must be mindful about electrolyte imbalances, especially potassium. Taking Lasix, we also excrete potassium, and we have to be mindful of that. Low potassium also leads to cardiac dysrhythmias. Okay. Another consideration also is kidney function. People taking Lasix, the one thing that you don't want to do is take Lasix but eat unhealthy or eat salty foods. Adding more and more water to your body is going to make this drug ineffective, therefore affecting your kidneys. The more we pee, the more we use our kidneys, and the more we're in trouble. So anyone with prior kidney dysfunctions should be mindful or cautious when taking Lasix. With all of these drugs combined, you can combine them in different forms through your doctor, but everything here that we've learned and we gathered treat CHF, okay? But the biggest thing that you can take away from congestive heart failure is lifestyle changes, exercise, and knowing your medications and how it works. Thank you.